Bismillahirrahmanirrahim. Assalamu alaikum. Today I am going to perform the CPR on the pregnant woman. That is in a drill, so every obstetrician must know how to perform the CPR in the pregnant woman, because we, being an obstetrician, we face lot of the women who are collapsed in the labor room or who are collapsed in the OT or in the ward, and if we don't start the CPR within the time and proper CPR, we can lose the mother. So every obstetrician must have a practice of CPR on the pregnant woman. The CPR is little bit different in the pregnant woman as compared to the non-pregnant woman because of some physiological changes in the pregnancy. In the pregnancy, the diaphragm is pushed higher up because of this gravid uterus. The diaphragm is pushed higher up. So when we start the CPR in the pregnant woman, we start the compression little bit higher up in the chest, in the middle of the chest, as compared to the lower one third of the chest. In the middle of the chest, we perform the start the compressions. The second point of that, when we apply the AED leads, it's also little bit higher than the non-pregnant woman. And if this woman is injured and she needs the chest intubation, so chest tube also applied higher than the non-pregnant woman. These are the physiological changes. And in the physiology, because of this gravid uterus, there is pressure on the inferior vena cava, and return of the venous flow towards the heart is reduced. So when we do the CPR, we displace this uterus on the lateral side. With the help of assistant, we displace this uterus on the lateral side. If we don't have the assistant and I am alone on the scene, then I will put the roll under the left hip of the patient. So there is little tilt on the 15-degree that will release the pressure from the inferior vena cava. So these are some physiological changes and some physiological modification in the pregnant woman about the CPR. If we use the drugs in the CPR like the adrenaline, amiodarone and atropines, so amiodarone is category D. All other drugs are category A and B, we can safely use in the mother, but amiodarone is category D drug that is not used in the pregnancy. So about difference in the CPR in the pregnant from the non-pregnant woman. So what are the reversible causes of the maternal collapse that can be treated simultaneously? If we don't treat the cause, the mother can again collapse. So these are divided into the 4H and the 4Ts. Coming to the H, the number one is the hypovolemia. Hypovolemia could be due to the bleeding, due to any cause in the pregnancy, especially the ruptured ectopic pregnancy, the ruptured uterus, placenta previa, abruptio placentae, postpartum hemorrhage. The postpartum hemorrhage is the leading cause of the maternal collapse in the Pakistan and in the developing countries. So hypovolemia could be from any of these causes. Hypoxia. Hypoxia due to the sepsis. Hypoxia due to the any cause. Shock. Hypoxia. Hypovolemia, hypoxia, hyper or hypokalemia. And the third one is eclampsia 2 in these cases. Now coming to the T's, there is the cardiac tamponades and thrombin, the pulmonary embolism, the thromboembolism and myocardial infarctions, toxins, sometime toxicity of the magnesium sulfate, sometime toxicity of the xylokines, trauma, the road traffic accidents. So these can lead to the maternal collapse. So these are the reversible causes, and simultaneously we can treat all these reversible causes while performing the maternal collapse, while performing the CPR on the maternal collapse. So coming to the CPR, there are some basic steps in the CPR. If we are on the scene and we see that the mother is collapsed, if I am alone, one rescue, we call this a one rescue or two rescue CPR. If the one rescue CPR, then one rescue CPR that will do simultaneously the chest compression and the breathing. If we have a two rescue, then one will do the chest compression and one will give the breathing. So how we start the CPR and where we do the compressions. So see the compression site, we do the compression on the middle of the chest. What is the position during compression? Heel of the hand, the dominant hand. See here, then the other hand, and this is on the middle of the chest. The position of the arm is straight. So full body force on this heel of the hand to compress the chest to start the activation of the heart. So heart will pump. So how much this deep compressions? These are about 2 to 2.4 inches. That is 4 to 5 to 6 centimeter deep. If we are going beyond that, that will injure the viscerals. So this is the recommendation. How much deep? This is 2 to 2.4 inches deep in the chest. So coming to these are the position of the arms. This is the position of the compressions. In between, allow the recoil and minimal interruption. During the CPR, the minimal interruption. How much compression we give? 30 compressions to rescue breathe. 30 compressions to rescue breathe. So for every 2 minutes, we check the pulse. Every 2 minutes, we check the pulse. We shift our role. If there is a to rescue, then shifting of the role, the person who is giving the rescue breathe will switch and coming towards the chest compression, and the person who is doing the chest compression will switch towards that to avoid the tiredness, because this CPR process is very tiring process. So to avoid the fatigue and tiredness in one person, we will switch over the role of the persons. So how we start the CPR, coming to the how we give the breathe. If I am the single person, suppose if I am the single person, see that, and I want a mask, if available mask, then make a C. Look towards the patient chest. So this is the single person. How I start the CPR. This is the woman who is collapsed. She is the case of the eclampsia and she is 24 weeks pregnant. She is the 24 weeks pregnant, gravida 2, para 1 plus 0. She is a case of the eclampsia. When I arrived in the labor room, she collapsed suddenly. So I am alone in the labor room. This is the single rescue CPR. I am alone in the labor room and my assistant is there. I'll start the CPR when once I recognize that this is the patient who is collapsed. I start with the shake and shout. Hello, Maria, are you okay? Maria. Then look, listen, breathe. So look whether she is breathing. Listen, not more than 10 seconds. Then if she is not breathing, check the carotid pulse. If there is no pulse, start CPR, start chest compression. Start chest compression. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 2, 3, 4, 5, 6, 7, 8, 9, 10. To rescue breathe. So in this way, we will do the CPR and call the emergency resuscitation team and ask your assistant, please bring the AED. Till the AED arrived, you have to continue the CPR and every 2 minutes check the pulse. Once the AED arrived, then apply the AED. So we are two rescue and we have an ambu bag. One will perform the CPR, the chest compression, and other will do this rescue breathing. So with this index and thumb we make a C, and with these three fingers we lift the chin up. 1, 2, 3, 4, 5, 6. So in this way, we perform the CPR in the mother during maternal collapse. Once the AED arrived, we apply the AED and clear off the field and see the rhythm, whether this rhythm is shockable or non-shockable. So if the shockable rhythm, then apply the shock and again start the CPR. So minimal interruption during the CPR while performing the CPR, minimal intervention, or this is of the change over the role of the persons who perform the CPR or when we do the AEDs. So this is all about how to perform the basic life support. Thank you.